get very familiar with the operating room, with needles, with procedures, and they end up being the ones who you come see with when pain comes around.
Dr. Alex Dressler,
Hello.
eShadowing. How are you, my friend?
I'm good. How are you?
I'm doing great. Thank you so much for taking some time to join me, staying inside that northeast lovely snowmageddon,
Yes.
and helping out these almost 800 students hanging out with us right now
Incredible.
to learn about anesthesia and pain medicine.
I'm excited.
Let's talk about what exactly is anesthesia and pain medicine.
So anesthesia, I think most people think about, in the operating room. You have to be asleep for some of these surgeries. People don't think much more beyond that. I think it's a necessary evil in some people's eyes, but there's a lot of great things that anesthesiologists do in the hospital, even separate from the operating room, that you may not know. And a lot of the pain doctors in the community are anesthesia trained, and you get very familiar with the operating room, with needles, with procedures, and they end up being the ones who you come see with when pain comes around.
Talk about, and I don't know if this is in your slides or not, but talk about pain medicine. I think that's going to be a new term for a lot of people, right? Anesthesia is one of those like core kind of specialties out there that most people are going to know about, but this kind of niche of pain medicine that it seems like you can get into from a few different directions. Why do we have a specialty called pain medicine? It seems like every specialty should be able to manage pain.
Yeah, and I think to a point, every specialty touches on pain, and usually it's related to what your specific thing is, and it's usually that short-term pain. So pain, for a week, for a month, but once you get into that 3-month, 6-month range, and you get through some of the stuff that people are used to normally doing, they get a little frustrated, and they tend to look to you for some of the advanced training on medications or procedures. And it's the stereotype is it's the 60, 70-year-old with back pain, and I'm sure everyone here probably knows a family member or friend that has back pain, neck pain, pain after surgery. All of those things end up kind of coming to us.
Yeah. Talk about bread and butter. I love talking about bread and butter. We've had lots of physicians say that the specialty that you go into, you have to be okay with and love the bread and butter stuff. So for anesthesia, pain medicine, what is bread and butter for you?
The bread and butter is the back and leg pain. People who have, and people probably heard the term sciatica. Sciatica is essentially to the public covers any pain in their back or legs. They have sciatica. And that's what we see the most. Your spine breaks down a little bit as you get older. It's a shock absorber that you're beating up for 60, 70 years. It's going to pinch on some of those nerves at some point. And that's kind of what falls under the pain bread and butter for sure. It's what I see the most of.
We have a couple students asking, what does bread and butter mean? And bread and butter is like, what are the most common things that you see in your specialty? So bread and butter, super common food, super common things that you see as a physician. Yeah. So from a treatment standpoint, right? Again, somebody says anesthesia, I think we can all picture intubating a patient, putting them to sleep. Obviously, you can't intubate people and put them to sleep for the rest of their life because of their sciatica. Yeah. What are some of the things that you are doing treatment modality wise for these patients?
Yeah, and on some of the slides, I'll touch on some of this. It's injections. Injections are probably the most common thing we do. We use a lot of steroids. Steroids to your whole body can have dangers. Not only blood sugar can go up, can break down some of the tissues if you're constantly getting exposed to it. It leads to all types of other issues because your body naturally makes steroids. It's the same reason that bodybuilders who inject themselves with steroids have issues long term. At some point, you're giving too much of it, your body stops producing it. It's a very, very powerful thing, your body at baseline. So we try to target those steroids, put them just on the nerve or the area that's causing irritation, and putting being able to use a very, very small needle the size of like a piece of hair, is a very useful thing, and that's kind of what we do a lot of. And pain, but beyond that, pain has expanded a lot in the last few years into things like electrical stimulators, some implantable devices we do a lot of now.
Very cool. Well, I want to jump into your presentation. We can see what's there. We can follow up with some questions based on what you have there as well.
Yeah, that's perfect. So kind of we had talked a little bit about this. So the pain doctor, how do you get there? Most commonly, if you looked at 100 pain doctors, a big chunk of them are going to come from this anesthesia and physical medicine and rehab background. It's you spend a lot of time dealing with people's pain and people's function. The physical medicine and rehab doctors do a great job during their training on functional issues, post-stroke or post-injury. They do a lot of sports medicine as well. The growing paths now, though, there's a large number of neurologists getting involved with some of the nerve-based pain and headaches. Radiology, psychiatrists, emergency medicine. The division chief at University of Pittsburgh, where I did my fellowship, actually did his residency in psychiatry, and then did a pain fellowship at Brigham with a lot of interventional pain. So it's even from the psychiatry side, you end up doing some interventions. From the surgical side, the ortho spine does a fair amount of pain procedures, because a lot of times, although numbness or muscle loss is a major reason why they do surgery, pain is probably the biggest driver of them performing procedures. And then neurosurgery, there's a few groups within it. People who do mostly spine end up doing a fair amount of pain-related work, as well as the functional neurosurgeons. The functional neurosurgeons implant some of these, the spinal cord stimulators similar to pain, and they do a lot of also like deep brain stimulators and other peripheral stimulators. So they're able to put in some of these devices that maybe some of the pain doctors can't. So kind of coming from the anesthesia side, there's so many possibilities you can do with pain. It ends up getting divided between that chronic pain and the acute pain. Regional blocks. This is more surgery or perioperative focus right around surgery. A lot of your ICU doctors, critical care medicine doctors, are anesthesia trained. There's cardiac anesthesia, pediatric anesthesia. There's some other non-fellowship accredited things you can do as far as running the ORs. A lot of the OR management and optimizing the OR workflow is anesthesia based. And obviously the obstetric anesthesiologist, the OB anesthesiologists are the ones who are there for all the babies. So I do touch a little bit on my anesthesia days, because I do some anesthesia and some pain. There's really two paths. So sometimes you're doing your own cases, so solo hands-on cases where you're the anesthesiologist is the one in the room the whole time doing the case. This morning I worked at one of the surgery centers. I worked with some of the spine surgeons, and I did their anesthesia for them in the morning. I did myself, and then I was there in the afternoon to do some of my procedures, which we'll go over. One of the other options is some of the medical supervision, where you have the nurse anesthetists. These are nurses who worked, around the OR and in the intensive care unit, who are very, very highly trained, who then do more training in anesthesia. And sometimes there's an anesthesiologist who's supervising a few different operating rooms going on at once, and to kind of make sure everything's going well there. But they're the ones who are physically in the room for a period of that case. Things we look at for the preoperative times, obviously the not eating before surgery is huge on the anesthesia side, as well as on the even if you're doing some of these pain procedures under anesthesia, you need to make sure that they haven't eaten anything, because of all of the risks associated with that. Things you want to look at in your preoperative evaluation, the same things we look at as a pain doctor too. Their past medical history, their past surgical history. You want to make sure that there's any of their issues that may be contributing to why they need surgery or why they have pain, that you're addressing those things. And kind of like what you were saying, that you anticipate anesthesia, you should put a breathing tube in. There's machines that can do some stuff and keep them safe. That's not the whole story. I think most people know that. Unfortunately, TV portrays the glorious surgeons doing everything. it never, the anesthesiologist is that like quiet person behind the drape who looks like they're not doing anything. In our anesthesia evaluations, you're looking at, their airway is one of the most important things we look at. And this is if you end up doing in-person things with something anesthesiologist, you'll hear Mallampati scores. And Mallampati score is basically what we're looking for in their mouth, predicting how easy it is for us to be able to see their vocal cords and safely put the breathing tubes in. And this just shows how to properly really align, your view when you go into the operating room to try to get, this is, the dream view is seeing your target to get the breathing tube in. Not always the case.
How competitive is it in residency? Like you're the airway guy. Like you can get all 1 through 4 of the different airways.
Yeah, it's. I think it's interesting. Everyone wants to be seen as like that go-to airway person, and when you first start, you realize how terrible you are at getting some of these views, and you see your attending who's been doing it for 15, 20 years come in, and you can't see anything. You're seeing, when you go in, you're seeing this terrible view. You can't see the vocal cords, and they come in and seemingly do nothing to change it, and then this is their view, this wide open, easy to stick the breathing tube in. And I put this is what you hear during the whole early part of the training. Just put the tube in. Like sometimes they don't see what's so difficult. And it's funny when you make that transition from an early resident when you're struggling to even a year later or half a year later when you're trying to teach some of the younger residents. And you're like, I don't understand what's so hard. Just put the tube in. It seems so easy.
Yeah. How much is it the preparation before you put the tube in?
Oh, it's all it's not all preparation, but it's 75% of it is you getting them in a good position, and people talk about the sniffing position to really line up. You want to line up your view. A straight line from their teeth down to that airway is gonna be your easiest way just to safely get it in there. And obviously, people who have had surgery on their neck or have muscle issues where they can't move their head, that leads to some difficult things. But there's new devices that are tricks of the trade to find your way in there safely. So once you get them in the operating room, your goal is, it sounds silly to say, but your goal is to protect them from the surgeon. Right? The surgeon is you have to think about it. The surgeon is doing something where they're either cutting something in or putting something in. You're assaulting this patient with their permission with sharp objects, and you have to do everything you can to keep them as safe as possible. While we're asleep, we're able to move and prevent any compression or being in one position at night. You see some of those like videos of people doing sleep studies. They're rolling around all night. If we have you completely asleep and not able to do that, there's the risk of issues with nerve compression or muscle spasming. So your goal is to really make sure that they're safe. And safe from people leaning. Once all those drapes go up, everyone starts leaning on the table and leaning on the patient. You have to make sure that people remember it's not just a blue drape. There's a person under there.
There's a human under there.
There's a human under there. You have to be careful. Things that we think about during surgery, their blood pressure is very important. I put hemodynamics, making sure that the anesthesia medicines affect how their lungs work, how their heart works. You have to try to keep them as safe as possible. You could think that just give them 100% oxygen, that'll be the safest thing possible. Not always the case. Too much of a good thing, just like anything in life, too much of a good thing can lead to bad issues. But the things that you always think about once you kind of reach a good point is you want to prepare them for the wake up period, for their post anesthesia period, optimizing their pain. And it's not always just pain medicine. It's some various medicines that affect their perception of pain, making sure you have all those things on board, trying to prevent, the NV is nausea and vomiting. The anesthesia medicines, the gases that people breathe to keep them asleep, make them very, very nauseous afterwards. So there's a lot of medicines that we can give them to try to prevent that. And also waking them up safely. Sometimes it sounds like counterintuitive, exactly the opposite of what you want to be doing, but sometimes you need to give them some long-acting sedating or relaxing medicines after general anesthesia so when they wake up, they're not going to hurt themselves or ruin the surgery that they just had done.
And so just a clarification, a student asked what NV means. I'm assuming nausea, vomiting.
Nausea, vomiting, yeah. So my current anesthesia practice, if you were to come follow me around now, I essentially do everything but cardiac. You can go back to that slide where there's 10 possible fellowships, and in the academic world, you do end up probably doing one thing more than another. In the private practice world, you go to a community hospital. Your team isn't really going to have 5 people that are designated to just like one specific thing. So now I do a lot of orthopedic surgery, a lot of nerve blocks, thoracic surgery. So surgery in the chest, just not on the heart, on the lungs, or on some of the other things in the chest. A lot of vascular surgery, ENT, ear, nose, and throat. You can imagine there's a lot of these. You think about how many kids get ear tubes or get their tonsils out. They're not long surgeries, so a surgeon can often move through a large number of those through the day. In the hospital I'm at now is a level 2 trauma center, which has at least one anesthesiologist in-house all the time. So I do take, even though I do mostly pain, I do take anesthesia call, and still have the pleasure of sleeping in the hospital at times to be ready for traumas that may come in.
Is it any better as an attending than it is as a resident?
It's at times, yes. I mean, the respect level when you show up to traumas is definite.
I'm speaking more for accommodations. Like, is the bed better?
So I will say, so again, as a private group, so we don't work for the hospital, but we're contracted through the hospital. So They give us a nice room, and the partners of my group have provided very nice accommodations. They bought a TV, they bought one of those adjustable beds.
Nice.
I think they'll do anything to keep us happy. So the transition from the anesthesia to pain side, to get board certified in anesthesiology, 4 years of residency, and they have just seemingly increased the number of tests you have all the time. So the PGY postgraduate year, so that's the year since medical school. So as an intern, you're a PGY 1. Traditionally, when people think about residency, you start as a PGY 2 and move on to whatever your length of study is. So now with anesthesia, you take a basic exam, which is another, I know it seems daunting with the amount of written exams you have to take. You take a written exam at the end of your 2nd year of training. You take the advanced exam at the end of the 4th year. And once you pass that, you take something called the applied exam. And for anesthesia, that means going down to Raleigh, North Carolina, where the American Board of Anesthesiology is, and you do half a day of an applied exam where you are tested on your ability to find things with ultrasound, do things with ultrasound, transesophageal echoes. So you're looking at the heart instead of looking at it through the chest. Anesthesiologists and cardiologists and other people can look at it actually going in through the esophagus. You end up behind the heart. And that's now a required skill with anesthesia. And the other half of it is you go through some scenarios to make sure that you're able to practice. And then there's the oral board period, which is very much like what you see on TV. It is 2 people sitting across the table from you, and they have 30 minutes to ask you as many questions as they possibly can. And you just make sure that they don't see that your palms are sweating the entire time.
What a question that came up, because you listed cardiac anesthesia as the only one that you don't do. Why is that? What is different about that? So you have to have our hospital doesn't have a cardiac surgeon. There's a hospital a few miles up the road that does a lot of the cardiac anesthesia. In the big academic centers, they'll always have the heart surgeons who are doing the bypasses or the valves in the heart. Or most of the big training programs at least will have those things. Out in the community, it doesn't make financial sense for every hospital to have that. So a lot of them will tend to gravitate towards certain things that they can have good surgeons, have good sets of tools in the operating room set up for them. My hospital just doesn't have a cardiac surgeon. It's less you lacking a skill set. It's more just the other person at the other end of the table isn't there.
And I will say with cardiac may be one of those things that I won't say 100% of people who are doing it did a cardiac fellowship, but most of them are. In anesthesia, you can get a basic certification to do that transesophageal echoes. So the echo where you're going in through the esophagus, you do the basic test. But with a cardiac fellowship, you get the same advanced echo test that the cardiologists do. So the cardiac anesthesiologists in their extra training are better suited for surgery because they're looking, as they're doing the changes, they look at the heart's function, at the valves. They're able to tell the surgeon, you may need to suture the valve more because there's a leak around it. And they're able to participate in the surgery a little bit more than I probably would.
Yeah. A couple of questions came in because we're talking about residency. Is the number of hours per week do you think you work during residency? And I know that the answer is no more than 80.
The answer is always no more than 80. Anesthesia is one of those specialties that you're able to have a life outside of the hospital. I wouldn't,
because the OR is pretty regulated, right? For the most part.
Yeah, for the most part, it's pretty regulated. You're going to do call. I would say 60, 70 hours is usually the upper end of what most anesthesia programs are doing. Not all anesthesia programs, I'm sure. Definitely a better situation than I know some of my friends in surgical specialties would document 79 hours, and that is what we will stick with. They never worked over 80. But they, you do what you have to learn. So sometimes you're there a little bit more, and you may stay because it's an interesting case you may never see again. And if you're at 65 hours and it means going over, sometimes you just don't document it. And I don't know if that's I don't know how close that is to following the rules, but you have to look out for what's best for you. Because you seeing that case in residency, may save someone's life in 5 years, 10 years.
Yeah, and just for everyone watching, we're joking about this 80 hours, 79 hours, because the ACGME rules are the average it's a 4-week period, right? Average over 4 weeks is you can't be more than 80 hours over 4 weeks, or the program gets in trouble. And so the standard kind of rule of thumb is you play along and you never work more than 80 hours a week, even though you usually do. Yeah.
There's definitely times where you may be a little bit over, and you can doc if you do. We at least kept track of our hours. You document it. You get this little red flag that says, "You sure you want to write that in? That's over 80." And you say yes because to be honest, most of the time you say yes because averaging it out over the four weeks.
Usually, okay.
The program sees that and maybe they cut you loose early on some days.
So another question came up that I love because I am a redhead, and the way that the student asked is, where did the fact that redheads need more anesthesia come from? Is it a myth? It's not a myth.
It is not a myth. It is, and it's you think it's going to be a myth, and a lot of times people come in, oh no, doc, it's so hard to put me to sleep. No one can ever get me to sleep. And most of the time you're like, yeah, anesthesia medicine always wins. But with some of the redheads, you're giving them medicine, you're sitting there, and they're just staring up at you, and you're like, ooh, all right.
Count back from 10, -3, -4.
You just, but it's true. It's the same thing with pain medicine, and I'm talking about like pain medicine with around an operation. Even nerve blocks, running the epidural. Sometimes we put catheters in people's backs to help with pain. A little tube in the back. They need a little bit more, and it's the percent is always, you'll see it reported in different places, but usually like 25-30% more. And, maybe you're not double tripling what you're normally giving, but there's almost always a little extra.
That's fun. And then another question that I've seen a couple times, just because it's a fun TV scenario, is how do you make sure the patients stay asleep?
So you can tell. So you can, because a lot of times we do give. Unfortunately, I wish they weren't called this, but people call them paralytics. Mm-hmm. You relax all of the patient's muscles. It makes it easier for surgery. It makes it safer to make sure they're not moving. So yeah, the question is, if you're relaxing them and they can't move and tell you, how do you know if they're awake or asleep? There's different ways. So there's a BIS monitor, which is this little sticker that you put on someone's head. That's the same thing. Neurologists do EEGs. They look at all the electrical signals coming from your head. Someone developed this little band that goes across, and it can measure. It measures all the electrical signals, and it outputs a number that gives you an idea of how asleep they are. I don't use that. I don't use it because the data on it is questionable, because the company who put it out is actually the same company that funded the studies behind it. So there's always some question. Some people love it though. Some people swear by it.
Yeah.
If you can watch how fast they're breathing. You can watch their heart rate. Even with everything relaxed, if they're feeling pain, if they're feeling discomfort, their heart rate will shoot up. If someone was awake, if someone was awake and we have their muscles relaxed, you can think about how scared they would be. Their heart would be going, 150, 160. It wouldn't be the normal, 60 to 80 you're seeing in most people. So you do see that sometimes people get, when people talk about anesthesia, they get light. If someone's getting light, or you're not at that right anesthesia plane, sometimes you can tell with the heart rate.
Yeah. Okay.
A lot of it is kind of laws of averages. You're looking at what the average person will need, and then from there you determine what each individual needs.
All right.
So with all that anesthesia training and how great anesthesia is, like, how could you leave the OR? You put in all this work, and I got asked this by some of the people who trained me for anesthesia. How could you leave this? You're not really leaving it. You're just adding a new special skill set of your own patients. And the reason I did it is because the more patients you talk to, you realize if someone has pain, it's affecting them every second of the day. It's some people don't. I used to say every waking second, but my patients point out often, well, I don't sleep, so it's always awake. And so you're affecting their quality of life. You're affecting their ability to spend time, with family and play with grandkids or kids. And plus the interventional side, it's fun. It's fun to do the procedures. It's satisfying to do a procedure and have them, hop off a table and tell me how great they feel. My typical days, it's every day with the pain, it's a little bit different. I have one of the offices I work in. I do office visits and procedures kind of back and forth depending on what the needs are. Like one of the surgery centers I was at today. So the surgery center is usually usually 1 to 5 operating rooms, so much smaller than hospital, typically private owned. You're able to do these same day surgeries. So surgeries that if people don't need to stay over, no reason for them to go into the hospital and be exposed to a lot of the risks of just physically being in a hospital, especially now with everything going on. And patients also say it's just much more convenient. The check-in process is shorter. The check-out process is shorter. Everything's very streamlined, and it tends to be very focused and specialized. So I do procedures in a few of the surgery centers where it's patients that you've already seen. They're coming in just for the procedure, and usually it's because you had to get insurance approval. You couldn't do it that same day.
A question that just came up, and I thought I mentioned it earlier. To go into pain medicine, there are a few different routes, right? You don't have to be an anesthesiologist to go into pain medicine.
You don't have to be an anesthesiologist. So I think the most common you're going to see is anesthesiology, physical medicine, rehab, the PMR doctors, and then some of the other specialties are getting much more involved. So we talked about neurology does a lot with their focus is on the nerve pain and headaches a lot of the time. And then radiologists who do interventional procedures are very familiar with the imaging side of it. They're familiar with some of the procedures. So a lot of times they do the pain fellowships to learn more about the medicines and general treatment pathways that they may not have learned during their radiology training. But they're very, very skilled with using some of the radiology techniques and the X-rays. So they're a great asset. And then emergency medicine, it's very interesting. There's more and more emergency medicine doctors doing pain. Not a huge number, but there's usually a handful every year who are applying for pain fellowships. And they can bring those skills into the ER and try to prevent some of the admissions into the hospital, which is a great, it's good for patients, it's good for the hospital systems. So the last part in the typical days is I do some procedures in the operating room. I do some surgical implants. So you flip from one side of the drape, from the anesthesia side of the drape to the other side, and I do some surgical procedures. And we'd kind of talked about this. The expectation of pain patients is one of two things. It's either grandma or grandpa who has back pain, or it's the drug addicts wanting pills. And really, that's the average age of my patients in some of the clinics are older, but it's not these 89-year-old everyone walking in with a cane. And I see very few. I see very few people coming to me for pain medicine. A piece of that is we have somewhat shielded in that a lot of our referrals are screened. You're able to see some of those things before they even get to you. And we also have a great team of nurse practitioners that helps us with some of that. And then, so you go from anesthesia to pain, and you're a subspecialist. And then some people go even further to subspecialties. I didn't even know what to call this. Within the pain world, there's people who focus on things even smaller. There's people who do mostly cancer pain, headache, pediatric pain. There's a large number of female pain and pelvic pain doctors, and then neuromodulation is something that I'll touch on. Is something that I think a lot of pain doctors do, and it's using some of these implantable electrical stimulators to change how nerves see pain, in sense kind of some of the outside things. So my practice, coming out, I do a little bit of everything, and I'm somewhat I feel like the go-to guy with my group already. Sometimes when they don't know what to do, sometimes when they're maybe it's a little outside of what their training was 15, 30 years ago, however long it's been with some of them, and especially the pediatric patients. A lot of the older guys in my group aren't really comfortable with the pediatric pain. I don't typically see people much younger than 14 or 15. And a piece of that is because Boston Children's is about 45 minutes south of me, and they have a very, very strong pediatric pain program. And I will say my practice is mostly interventional, but not interventional only. There is the ideal with a lot of people that you're just in it for the procedures. You don't care about the person. Just stick them with the needle, never see them again. And so I have a good relationship with most of my patients, and it's beyond just the interventional side. So I prescribe medicines, not a lot of the pain pills, but a lot of the other medicines that are helpful. Like I said, every day is different. I'm a big bow tie guy. So at each of the sites I work, we have a different lead. We have lead to protect us from the X-rays. I have lead glasses that have lead in the lens to protect my eyes so I don't get cataracts. And it's so at every place you get a lead, and I made sure at one of the newest places I had them sew a bow tie on the shield so I could it's just still feel fancy when they're making me wear all black.
That's awesome.
And then so what procedures do we mostly do? So epidurals. People think about epidurals with the pregnant patient. I'm not putting that little tube in there, but I do put steroids in to calm down some of the irritation on those nerves. And one of the common things with people saying that they have back pain are these facet joints. Facet joints are these tiny little knuckles that sit in between every level of your spine. So a lot of times it's bone, shock absorbing disc, and bone again. And the bones hook up outside with these little knuckle joints. And you can get arthritis in those joints the same way you get arthritis in your hands, your knees, your shoulders. And so we can put steroid on that. See, a lot of these procedures involve steroid because you're trying to decrease the inflammation. The same reason you take ibuprofen or Motrin, because you have something's inflamed. It's an anti-inflammatory. We basically try to put the anti-inflammatory right where the problem is. What is radiofrequency ablation? It's using a heating probe, actually heating the nerves up to very very high temperature, usually 80 to 90 degrees Celsius. and you numb up those nerves, but you put a heating probe in there, and essentially burn the nerve or stun the nerve enough that it doesn't feel anything. You can do that in the back and the neck. You can do it really in a lot of the joints. You just have to be careful. You stay away from the motor nerves. So when we think about nerves, you think about the sensations, so the feeling parts of nerves, and then the motor part of the nerves, the parts that are moving, moving the muscles. You obviously don't want to damage the motor part, the moving part, because although someone would appreciate not having back pain, they aren't going to appreciate it if they lose some of the strength in their legs. And there are ways to do that through some testing. Genicular is just a fancy name for some of the nerves that are in the knee. I see a lot of knee pain patients both before and after surgery, and that's part of it. Part of the other thing I was talking about a little bit about is iovera, is this cryoablation. So this one I heat it up. This one I use a gas to freeze it. That's become very, very helpful recently. We do it for TKA, total knee arthroplasty, so knee replacements. I'm able to freeze the nerves before knee replacements, and patients have done very well. So when we freeze the nerves, we have people taking no pain pills after a knee surgery. And if any of you do shadowing and see some of the orthopedic surgeons and see what a joint replacement looks like, the thought
that's incredible.
The thought of not needing pain medicine after that is awesome. And then just talk about some of the other stuff I do. So the more advanced procedures, so spinal cord stimulation, putting and I have a picture coming up, putting a little electrical leads outside of the spinal cord to send electric signals. And there's a lot of the idea of how it works is very detailed and probably would be a 5-hour talk on its own. But I always boil it down. The initial thought was this idea of gait theory. So everyone here who has hit their elbow, hit their knee, and rubbed it afterwards, and for some reason, although you just hit your elbow on a desk, right, and you rub it, it doesn't hurt as much. Your body can only sense so much coming in at once. So if you put a non-painful sensation, it used to be a little vibrating sensation, you send that and you block those pain signals. It's been discovered that it's a much more advanced thing than that, but that's kind of what the easiest way to explain it. And that's just leaving some of these electrical leads right outside of the spinal cord. And then we can get even more focused now, and I can find one specific nerve. And if it's in the back, I can put a stimulator on it. Dorsal root ganglion is like a bulb of nerves. So all the nerves, before they go out and spread out, you have a little bulb of things together. And if some of the pain is further out, that's when we use things like peripheral nerve stimulation. So peripheral, further out from the center, we can put some of these little electrical leads under the skin. Superion is a one specific company, but for people that have breakdown of the discs in their back, the shock absorbers go away and you have bone on bone. I can actually put essentially a car jack between the spinous process, the parts of your back that you feel, those bones that you feel. I can put a little car jack in there and separate them out to create a bigger space. And these are just some of the pictures of some of the procedures. So spinal cord stimulators, I put these typically two electric leads in the midline of the spine, and it's just like a battery. You're using the plus and the minus. You're making each one a plus and a minus. You're sending signals between these to try to trick the spine into not feeling pain. Whereas those little bulbs of the nerves that we talked about, the dorsal root ganglion, is when I would feed the leads out a little bit, coming out into the nerves. And this is the very fancy car jack that we do. And this is the handheld iovera device, the freezing device that we use. So there's a lot of techniques, but like, how do we apply this to patients? And like, what is my typical patients? What am I seeing now? So very common is, you're seeing not that old 80, 90-year-old patient. You're seeing someone, in their mid-50s, otherwise healthy. They try to be active. They come in with back pain.
As you start in on this, I'm gonna invite a couple students in to see if we can ask them some questions. So if you want to come in and try to answer some of these questions as we go through these cases, make it fun and see if we can pimp some people.
So everyone's first stop with back pain is they're going to see their primary doctor. It's the person they know the most, and we've just spent 30 minutes talking about anti-inflammatories. That's the first thing they'll try. They'll try anti-inflammatories, try physical therapy, and pain's not getting better, and now the pain's actually getting worse. So it was just in the back, now it's going into the legs. So at this point, what would you're trying to figure out what's wrong? What do most people think the next step would be?
So Shane, you're in the room. Can you turn your microphone on? You can discuss here.
Hi. So I think I missed the first part of this. So I see. I'm just reading it real quick. Very active, 6 months, increased back pain. Very active. I guess maybe I would ask, I pictured like biking, maybe did you like get a new bike that maybe has like more pressure, doesn't absorb shock as well? Are there any habit changes in those hobbies that may have brought on that back pain?
Yeah, and I think that's one of the first things is you have to see, what's changed. And sometimes they may not come forward. It's like, oh yeah, I tried a new bike, or I'm trying a new trail and I fell, or I was trying a new, I switched bikes and the back pain's getting worse for any of those reasons. Maybe he loves his new bike and he went from biking once a week to 6 days a week. So I think those are all good places. Those are all good places to start and figure out the changes in their habits. And you can try to modify those. So you can try. You say, if you go back to your old bike, see if things get better, or take a break from the biking or hiking or skiing and see if things get better. If things aren't getting better, a lot of people, or if they had a fall, you'd go to an X-ray, make sure there's no issues with the bones. So let's say that things aren't getting better, and they, so then they come back to the office and things are getting worse. The radiculopathy, more pain is going into the legs. It's affecting all the things that he likes to do. So he can't bike, he can't ski, he can't hike. All of those things are worse. And you try to order an MRI. So you're looking for this more detailed picture to kind of see what's going on. And I had to take a shot at the insurance companies. Always you order an MRI, and it's denied. It's denied. They'll find a way to deny it because they don't want to pay for it. And so they say inadequate conservative measures. So does anyone know when people talk about conservative measures, what they're talking about?
What do you think, Shane?
Are there other imaging workups that just aren't as expensive that they want you to do first? Is that what that's getting at?
Yeah. So a lot of times, if you haven't gotten an X-ray, they'll want you to get an X-ray. CAT scans are a little bit cheaper. And a lot of times they'll go for those because they're easy to get approved, but don't show us the same soft tissue things that we need. But a lot of things they'll try. They want you to try, when they talk about conservative measures, they want to make sure that you've tried a lot of these more non-invasive things. So physical therapy is huge. Insurance companies, at least for me, draw the line at 6 weeks of physical therapy. So trying to see that if there's ways to do this without them, having to get an MRI and potentially do something more invasive, if we can get away with that.
And it's pretty standard, right? It's pretty standard that a lot of back pain will get better with start moving, start stretching.
Yeah,
you'll get better.
And it's one of the most frustrating things is getting patients to do physical therapy because it's not the fastest thing, but honestly, it's what's going to give them the most long-term relief, and get them kind of in the best shape. You see people wearing back braces, and the reason they do that is because they're concerned about their back not being stable. But what you really need to do is that core strengthening. The physical therapists work with you. You need an internal back brace. So if you have a strong back, strong core, it takes the pressure off the bones. And then they look for medication. So could a few weeks of anti-inflammatories or Tylenol or some of these medicines that may cost the insurance company 20 cents, is it better than an MRI that's going to cost them a few $1,000s? And so that's what we did with this patient. We gave them gabapentin. So gabapentin, I see the whole body as like an electrical system for the most part. So gabapentin is a medicine that initially was approved for seizures. So people that were having seizures, so bad electrical discharges causing seizures in their body. But we use it for the same reason. You have bad electrical discharges from something fraying a wire in your back. If the bone or the arthritis is peeling off some things in your back, that's why you're having these electrical shorts, or you're short circuiting your leg basically. So we brought that up from an initial dose of taking it 3 times a day, TAD, brought it up to 900 3 times a day. And they were doing better, but not great. So then obviously try your best to reorder the MRI because you think that's what's right for the patient. You want to see what's going on in their back. And they initially say no, but you do a peer-to-peer. And I have to always put peer-to-peer in quotes because in all of the times, in every peer-to-peer I've done, I've only once had a pain doctor be on the other end of the phone. And it was the quickest phone call I've ever had. It was the best. I told him why I wanted to do it. And his response was, yeah, sounds good. But most of the time you're trying to convince someone who isn't as familiar with what you're doing, why it's the right thing to do. And they have a pathway in front of them and a piece of paper, and they get paid. The insurance companies pay them to say no. So it's your job to convince them to say yes. Sometimes you do it, sometimes you don't. In this case, we were able to do it, and it was great. So then we get an MRI, and MRIs take a lot of time, a lot of practice to look at. So again, we're not gonna hit on everything, but what a lot of times what I'm focusing on is this disc. So the disc is this material you see as a circle, typically in the MRI, and this is cutting them essentially like a tree. So you're cutting like a tree trunk across. And what I look for is I want to make sure that this white circle, this is the water balloon that all the nerves float in. Call it the fecal sac. So it's all your spinal fluid. The nerves are floating in at this level, and you can kind of see these little black dots floating in that water. I want to make sure that they aren't getting squeezed in any area from this disc material. And I like this picture because it shows a lot of things all at once. You can see here, this beautiful white circle. You don't really have it here. Here, you see it getting pushed down a little bit. So any of these small changes, and they can be very, very small changes, that push those black dots, those nerves that should be freely floating. They should just be floating around in a water balloon. They're getting pushed off to the side. That's what leads to these people's pain. So this is the MRI of our patient. Difficult to see on this cross section. You can see it looks, compared to that last slide where it's this beautiful white circle, looks like it's getting squeezed. You can see the fluid is pushed in the back. Hard to see the nerves at some points. And this is actually that same picture, but from the side. So you can see these are the discs. These are the shock absorbers that we look for that are taking a lot of the brunt of the weight of your body. And in this picture, the white is the fluid. So you have a normal disc, a normal shock absorber has some fluid inside of it. You can see in this specific patient, small here, and here you're wondering, where's all this fluid? Why is the disc so dark? And that's because it's dried out. And when they get dried out, they get weak. And you can see here, this looks like a thumbprint, like someone's pushing their thumb into the water balloon. They're squeezing the nerves, squeezing. It's below where the spinal cord itself is, but where the nerves that are coming off it are living. So you can imagine this looks nice and normal up here, this perfectly flat line. I think even if you don't know what the importance of it is, you can look at this, the right side, and see that's just not good. So we do epidural steroids. We talked about putting the steroids in, the anti-inflammatories in, and we can do it one of two ways. We could go in straight through the back, or we can go in through one of those little keyholes that the nerves come out of. And just why does anyone think one way may be more effective or better than the other one as far as getting to the nerve?
I can imagine that, one is more invasive than the other. If you get through that keyhole, you aren't going to be going through trying to cut through bone by accident,
Yeah. So one of the important things is you have to look at where's the squeeze. One of the important things, where's the squeezing happening? Is the disc coming out, nice and round, or is it coming out and squeezing it off to this side? If all the nerves are getting pushed aside, maybe you don't have to come in just one way. They can come in through the side. And the one thing that it's a debate within the different specialties, and a lot of times it depends if you were anesthesia trained or if you're physical medicine rehab trained. For some reason, there's a split on what people think, and I'm not going to expect anyone to know this, but this is what we think about. There's a thought is if you come in back, you're putting most of your medicine here, you're not getting a lot of these nerves through the front. But if you come in through the side, you're getting more. The medicine is splitting all around that water balloon, and not sitting in one part of the water balloon. There's studies that show that is true. There's studies that show that it's not true, and there's a nice even split. That for some reason there's a split in people's opinions. So you can oftentimes an anesthesia trained pain doctor will start with the injection in the middle coming in through the back. The physical medicine rehab people, depending where they did fellowship, will come in through the side. One way isn't right, one way isn't wrong. One of the important things, though, is that for a surgeon who's planning surgery, if they're worried about taking this disc out and they want to see, was it just this disc causing their pain? Because if they're going in there, they want to try to do as much as they can to help the patient. So, is it just this that's causing them pain? Could it be this little level down here that's causing them pain? So the surgeon sometimes will have us do those targeted injections. So the lumbar epidural, when you hear LESI, lumbar epidural steroid injection, the way this is used, people talk about it's typically coming in through the middle, through one of the openings in the back, and putting the needle on, usually on one side or the other, depending where the pain is bad. But the transforaminal, that was the TFESI, and this is all very in detail, so I won't go too far into it, is coming in through this keyhole, and you go into the epidural space through the side. And then sometimes you can see how instead of, you're not going to get a big spread of the medicine here, you spread it all over the water balloon. Here you're able to sneak it in through a small space, and this is just me using a little bit of dye to show that I'm in the right spot and show that it's going in the right direction. So with this patient, I started with an epidural. They have pain that's going to both legs. I can get both sides with one injection in the middle. And this is the dream. You do one, pain goes away. You do a second one, 6 months of relief. They're feeling great. They're racing on the Olympics next thing you know. So this is one where we do the conservative.
All right, Shane, I'm going to kick you out and we'll bring someone else in.
So now this is using that first case. So now 62-year-olds could be the same patient. They've aged 5 years, pain's getting worse, still going through their back and legs. We've tried conservative measures, didn't get anywhere, didn't help. So we bring them back and I do injections. Injections are good, but not really helping. Now, what do you think the next step may be?
So Parker, you're here with us. You might have missed that first slide. Can you go back?
Yeah, sorry, I did.
Sorry.
Here we go.
60-year-old male referred by his primary care physician to years of pain, back and bilateral leg pain down the toes. Interesting. Okay, so I think it's interesting that it's bilateral rather than just one side. So I think you can kind of, whenever you're trying to figure out what's going on, start large, then try to narrow it in. So like we said before, maybe try to see what kind of habit changes there are. Did he try something new? He is a little bit older, so I would assume he's going to be a little bit more liable to getting some sort of injury. So I would definitely be asking if he did anything new. Maybe, he took the grandkids on a walk or something. So I'd definitely start there with something. Did he do anything new? Being it bilateral would make me think that maybe it's not really a leg-related injury. I would think maybe a lower back. So that's where I would kind of start.
Yeah, that's perfect. That goes to we had talked about bread and butter. This is for pain doctors. Back and leg pain is our most commonly seen thing. The bread and butter. And they can, sometimes exactly like you said, they're not presenting with not showing up with just knee pain or just foot and ankle pain on one side. If you're having pain in the back and pain going down the legs, it's typically coming from that lower part of your spine. And unfortunately, I don't have a picture here, but if you look up skin dermatomes, you're able to trace out often without even getting a picture of their back where the issue may be. If they're having pain in the sole of their foot, a lot of times that's, you're looking at your L5 or S1 nerves coming all the way down to the foot. So just like you said, pain going down to the toes, I'm thinking low back. And 2 years of pain. So that's, it could be from something. Yeah, it could be from a change. And maybe he has baseline back pain and he did something that made it worse. But it's just whatever he's doing, likely isn't working. And he's tried those conservative measures. So he's done the proper amount of physical therapy. He's tried medicines. And then we as the interventionalist, I want to try to fix that. I want to make it better. So I do some injections, and they help, but they don't last. And that's often patients' frustration, is that, they feel great for a month, but it goes away. They feel great for 3 or 4 months, but it goes away. And they don't want to feel like a pincushion, and I understand that. As much as I enjoy doing them, I try to tell people if it's not working, we really shouldn't kind of continue on forever. So we've tried the initial part of what I do. And this is a good time to see what some of the other people that we work with can do. We talked about the neurosurgeons or the orthopedic surgeons. Even if you don't think that they need surgery, getting their opinion on where to go, 2 heads are always better than 1. But you also have to understand that a surgeon likes to do surgery. So we often don't refer too soon. And you're able to, in practice, find surgeons that you get along with. And that you look for those conservative ones that only operate when an operation will help and don't operate just for the sake of operating. So they show up and they're mad at me. They're frustrated. The injections aren't helping. They were helping, but now they're not. So I send them to a surgeon, and the surgeon says, "Oh yeah, they definitely need a fusion. Let's put some titanium in them." Before I wanted to do pain, up until 4th year of medical school, I was actually thinking about doing neurosurgery. Spent a lot of time with neurosurgeons. I had one who told the patient they had a titanium deficiency and that they were there to fix it. And that titanium deficiency is these screws and rods that they will put in to help. So in this patient's case, exactly like you said, it was low back and leg pain. The bones were too close. They were pinching those nerves off. So put a little metal in there, stretch everything out. And it's great. 2 years, back to biking, hiking, running. The pain starts to come back. And you can think about this even separate from the medicine side. If you're building something and you make one part very, very stable, and almost like unnaturally stable, when your body still has that much pressure, where the issue is going to go, they're going to go above and below. So often when people get these rods in here, we see some degeneration, the disc space above taking more pressure because now the metal below it isn't taking any of it, or even these little joints between the hip and the bottom part of the spine, those joints end up taking a lot more pressure. So the surgeon says, "No, nothing I need to fix. Go back and see your pain doctor." So what may be a good next step now? If the surgeon says from a stability standpoint, everything's stable, solid, good to go.
Ooh, that's hard, especially after the neuroscience is referring back. Definitely with the first thing that comes to mind when thinking about pain is that it's really broad, it feels like. So like I know one thing that I learned about is a lot about referred pain. And so one thing that I would be curious about is maybe that there's a cause that's not necessarily in the lower back region, maybe that there's some other physiological aspect going on that's causing some sort of referred pain. And so that'd be, since I don't know too much, but as specific as I get is maybe that there's something a little bit greater. There's a referred pain. Maybe we're looking in the wrong area. Definitely worth exploring and zoning out a little bit.
Yeah. So it's, although they only have the rods here to get a view on in surgery to get there, they likely made an incision that's much larger. You have scar tissue above and below. So scar tissue could be pinching nerves close to the spine. Scar tissue could be pinching on the nerves further out. Like we had said before, just because they took the bone off and put a nice like a scaffolding to keep everything safe, you still have your nerves are still living in there. So the nerves could be pinched by the scar tissue that we just can't see on this specific picture. And a lot of times it's pain coming from above or below. So now so this patient says, my friend has a pacemaker in their back. I want the pacemaker in my back. That took away all of their pain. So initially, spinal cord stimulators were pacemakers. They were stole a cardiologist's pacemaker and put it in someone's back. And luckily, the technology has advanced pretty significantly. It used to be you'd put these in, and people would feel vibration in the area that they had their pain. So they'd have vibration going down their leg. They didn't have pain. It was a sacrifice they were willing to deal with. And then it went all the way in the opposite direction. They found out that if you stimulate at such a high frequency, your body can't even perceive it. So there's one company that had 10,000 hertz. You couldn't even feel it. But again, you're closing that gate to the pain signal. And companies have advanced with different algorithms. And one of the common ones now is burst stimulation. Dirk de Ritter is a very famous neurosurgeon. I think he practices in Belgium now. Who looked at the nerve signals that your natural body makes. He's like, why don't we just make the stimulator do that? And it's been incredible because your body could use those signals to stop the pain, but also it's helped with a lot of other things. It helps with function, it helps with depression. So I bring the patient in. I talk to them about the spinal cord stimulator. I explain to them that it's like a test drive of a car. So I put a temporary one in. I tape the battery to the outside of their body, and I have them go do whatever causes them pain for a week. If it's standing too long, if it's walking too long, I want to see if this is going to help them in their day-to-day life. So I send them out. So they come in, and this is actually something that we can do in our office. No sedation. I just numb them up with just some lidocaine in the back and put in 2 needles. I put in these thin electric leads, and these leads are, they're a bit bigger than fishing wire, probably not as big as the cord of on like headphones. And you drive them up there under live X-ray, and they sit here, and we're able to send electrical signals between the different points, and we can map out where on their body their pain is, and hopefully close that gate to the pain. So I tape them up. They go out. They come back to the office. And they say, it's great. I don't want this ever to come out. So now the question for me is, are they a candidate for me to do this? Where I put these leads in, and then under the skin, I use a small tube, like a tunneling device, and I put a battery right around their hip. Or is this a patient who I think would be better to see one of the surgeons? And the surgeon actually does make an incision. They take out a little bit of the bone, and they put this paddle in. So if you ever go down the pathway of pain, you'll hear about percutaneous through the skin or paddle leads. And paddles are the things the surgeon will put in. It doesn't look as it's not as long as mine, but it's a little bit wider. So there's the question of if it's just one spot and you can cover it. Hopefully, the patients like you, they want you to do it. You do your percutaneous lead. I bring them to the operating room. Anesthesia MAC stands for monitored anesthesia care, and that's just like enough sedation that they're able to respond, but they may drift off asleep. So we put those 2 leads in, create a little pocket for the battery, a non-rechargeable battery stick kind of in the area that everyone has, a little bit of fat right above their hip bone. You can stick a battery in there. These batteries last 5 to 10 years. You can change them out with just numbing medicine now. They come back to clinic. My incision where I open the battery hurts a little bit, but otherwise no pain going down their leg. They go back to, almost the commercial level of bliss and hiking and running and whatever they want to do.
Nice.
So this one, I don't know if you want to move on through this case. Yeah.
Yeah. Let's stop there. Some great cases. I'll respect your time running over here.
Sorry.
Dr. Dressler, thank you so much for coming on, sharing your wisdom, sharing some really cool cases, some great images. Hopefully we'll get some people interested in pain medicine. So that's really awesome.
That'd be great. And easy to find on the internet if you have any specific pain questions. definitely, I'm open to any questions.
Nice. All right. Thank you, everyone, for coming. Thanks, Parker,
Thank
for coming
you.
on and playing along.
Thank you, guys.
Yeah. Bye.